This week, I had the pleasure of sitting down, virtually of course, with none other than Russ Horowitz. Now, Russ is an EM physician that specializes in pediatrics and also likes ultrasound. Now, he is super focused on good patient care, and with that comes the utilization of ultrasound in the diagnosis of pediatric pneumonia. And we're going to talk about all sorts of tips here, from the literature behind it, how to incorporate it in your daily practice, even if you're in a place that maybe they're not super comfortable with utilizing lung ultrasound as an institution. We're going to talk about how to even hold the patient, how to adequately warm gel. We're just going to touch on a lot of topics on lung ultrasound to get you started. Now, before I begin the interview, I just wanted to tell you about a couple of conferences that we have coming up in which the registration is now up and running. Check out castlefest2020.com and benfest20.com. Now, CastleFest is a conference in my hometown of Lexington, Kentucky. Now, it's called CastleFest because it's actually in a castle. And in this castle, we're going to have 4 days of just phenomenal ultrasound teaching with world-class experts giving lectures, helping out with hands-on. And we're actually going to have a pre-conference course where we're going to have an EMS conference, a course on just how to do ultrasound guided IVs, and a course on content creation and how to lecture. That's going to be May 4th through the 8th. We are also having another conference in Bend, Oregon, which is Mike Mallon's hometown, and that's going to be in July. Check out the website for more specifics. Now, on to the podcast.
If you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
Yeah, we can definitely do that, or we could be better clinicians and use our ultrasound.
Hello, my name is Jacob Avila of the Ultrasound Podcast. I have with me a special guest, Russ Horowitz. Now, Russ and I met, Russ, we met at least a few years ago, right?
Yeah.
Just nerding out about ultrasound stuff. Russ loves ultrasound. He also loves seeing kids. It's kind of his niche within ultrasound. He is the director of the Emergency and Critical Care Ultrasound at Lurie's Children's Hospital, and that's in Chicago, right?
Yep.
Yeah, right on. And we recently, the last time we saw each other was at ASEP in Denver a few months ago, and you gave a talk on using the probably, I think, the best, I mean, that's completely subjective, but the best application of ultrasound, which is lung ultrasound, in the population in which it's probably the most helpful, and that's kids. Russ, do you mind kind of walking us through this lecture that you gave at ASEP last year?
Yeah, sure. Thanks, Jacob. Hi, everybody. So I guess when I first started doing ultrasound, I kind of got real excited about things like appendicitis and pyloric stenosis. And even though those are great, I still have to rely on general radiology and surgery to make an action based upon what it is that I see. But lung ultrasound in little kids is great because I can then start getting better and better at diagnosing pneumonia, minimizing my radiation and time that kids are away from the emergency department, and then treating it in a weird way like sort of an ear infection where emergency physicians can make that diagnosis and patients get seen. And if they have the ear infection, they get their antibiotics. If they don't, they don't. Lung ultrasound is actually a really easy tool because we're just looking for a difference in patterns between one area and a neighboring area. A little bit more detail is that the easiest way to scan, although there's some research protocols that talk about dividing the lung into a bunch of different segments, is I just do what's called lung sweeps. Take the probe in a sagittal plane with the marker pointed toward the kid's head. Although I got to tell you, if you're confused and you're a novice and the probe is transverse or the marker is toward their feet, you're still going to get a picture of the lung, so it doesn't matter.
Agreed.
And I just start, let's say, it's the easiest one is to start in the kid's back because they're usually a little bit unhappy. So they're hugging the parents and just do right side, left side, slide the probe right down the mid back, stop at each rib space. And then you just see traditional A lines, normal boring lung. And as you go from rib space to rib space, when you start to see something like B lines mean water, right?
Mm-hmm.
So if you see
Well,
a collection of
they mean increase in density technically, right?
increased density, yeah. So
Yeah.
the sound waves, thanks, yeah, for the clarification. The sound waves now can travel through that area.
Okay.
Once I see a beeline, then we say, is this an area with some increased density, some fluid, water, consolidation? And in the case of pneumonia, there's additional things that you will find. You see lung hepatization, so your lung starts to look like liver. But remember, you're the one holding the probe, so you know that it's not liver because you're not over the liver. And then you will see air bronchograms, which are little white tubes or collections of little white dots. And the distinction between what we do and radiology does is radiology says it's either atelectasis or infiltrate, but of course they can't tell because they're looking at a still picture of a dynamic exam. So they don't know if that air
And
bronchium
apart from the
moves.
patient, right? I mean,
Absolutely.
they're I mean, and nothing against our radiology colleagues. I mean, we need them, and they do a phenomenal job, and we can't function without them. But we are doing the scan after we've already kind of done our history, done our physical exam, maybe even ordered some other tests. We have everything right there, and we're doing the ultrasound.
Yeah. So you get to have an idea of where the person has chest pain, where the person has a change in sounds. However, that being said, the auscultation is not good at all. All the science says it totally stinks. Sorry, blew my mind there.
No,
Totally
it's crazy.
stinks.
I mean, in medical school, I was taught that auscultation is key and that you can make diagnosis based off your clinical exam. I was also taught about agophony. I was taught about whispered pectoriloquy, and I was taught pretty heavily on the whole percussion business. Now, before we go on and talk about like the limitations of that, I want to go back. You mentioned that it seems like you start in the patient's back. Is that like where you start? I think that that's a very important key because most of the kind of beginnings of lung ultrasound has been looking for B-lines in the setting of cardiogenic pulmonary edema. And this is like as a whole, not just with pediatric patients, looking for pleural effusions and looking for pneumothorax. All of those disease processes are really evaluated in the anterior in the setting of B-lines or pneumothorax, or in the lateral, which is a pleural effusion. But to really evaluate for pneumonia, you have to look at the back. You have not done an adequate examination unless you look at the back. I mean, statistically speaking, the right lower lobe, which is the back, by the way, because, the lungs are all kind of like diagonal.
Yeah.
The right lower lobe is the most likely place for pneumonia to be present. So you can't not look at the back. So I love that you start exactly, where it's most likely to start. Because I don't know if this is how you are, but for me, lung ultrasound is binary, at least as far as pneumonia goes.
Yeah.
If I find a pneumonia, like I have my diagnosis, like I don't have to look and see if they also have more pneumonia, like they have pneumonia, right? And the ultrasound is going to give me that diagnosis, and finding more pneumonia somewhere else is not going to like change the diagnosis of them having pneumonia or not. So brilliant point. The other question I have for you is you said that you had or a question, I guess, that I have for you is you were mentioning, atelectasis versus consolidation with B-lines, right?
Yep.
So, I mean, what do you do if a kid's got like, I don't know if you're going to get to this later, but what do you do if a kid has like cough, doesn't look that sick, low grade fever, maybe like 100.4, 100.5 with some focal B-lines without a consolidation? Like, I think that's where like, and I'm sure you're going to get into this later, but that is like the thing that's the most frustrating, I guess, about lung ultrasound in kids in general, honestly.
Yeah. And I can understand sort of the process. As I've done a little bit more, I start to have the smaller sort of binary answer. So at first it was just, do I see B-lines? Yes, no. Focal B-lines make me think that there's something in that spot. But then when you get a better view, you can start to identify that rib space. So imagine you're sliding down and you're sort of the fourth rib space from the top. You start to see some focal B-lines. And you go, oh, this is sort of the clue. Okay, there could be something here. So then I slide right a little bit, left a little bit, and I'm investigating that area. The other things that we find are lung hepatization. So it looks like liver. So that's in a density. And you can see the air bronchograms, which will be little white dots, appear in tubes. Now this is when...
What causes that hepatization? Like, why is it called that?
So it has the appearance of liver.
Interesting. Okay.
And that has to do with a similar sort of consolidation or density, kind of like liver.
Because now you can see lung, right? Like before you couldn't actually see lung because it was full of air, and now you can actually see lung tissue, which is abnormal. You should never see lung tissue on ultrasound, right?
Absolutely. So in the case of infiltrate, then I like to think about it as water. The traditional starting point of lung ultrasound sort of said lung water. We don't know what that water means, but there's a collection there. So normal air-filled lung just will reflect the sound waves, and all we really see is pleura. And then those reverberation artifacts, the A-lines. But when you have lung water in a small area, that says, of course, not pulmonary edema, because that would have to be on both sides diffusely. Then we see a small little area, and we start to look close. As you look closer, you get that lung hepatization, the air bronchograms.
So when you say lung, sorry to interrupt. So when you say you
please.
look closer, you mean like you're doing like your lung sweeps, and then you see B lines, and then you kind of like start honing in on a specific like area. That's what you mean by looking closer, right?
Yeah,
Not that you're
absolutely right.
like physically getting closer to the monitor, right? Like you're just like evaluating that area better, like more diligently,
Yeah.
I guess. Okay.
More diligent. Yeah, that's a great way to describe it.
Sure.
And then we will see little white sort of chains of dots,
Okay.
or chains of little white dots. Those are air bronchograms. So the air is sort of trapped in a space. Now, this is when we start to diverge from X-ray, because X-ray is a static evaluation of a dynamic process, breathing.
Okay. Yeah. No,
Now,
I like
of
that.
course,
That's good.
they can't tell whether those air bronchograms are stuck in mucus or they're moving as the patient breathes and gives more of a pneumonia pattern. And so we often get frustrated when the radiologist says atelectasis versus infiltrate. But of course they can't tell because they're not seeing the patient and they can't see movement.
Right.
But ultrasound allows us to see movement.
Yeah.
And when we see those little white dots bounce like little jumping beans or like a collection of coins. Yeah,
I've heard
toss
it
up in the air.
One of my I like that. One of my residents when I was in Chattanooga described it as pneumonia worms. She couldn't remember the word, so she called it a pneumonia worm.
I like it. I think any description that provides a visual image of what it is we see is the way that you would imprint in your mind something that you're looking for. And you're trying to create in your mind an image and then compare what you see to the image that you see that's pathologic or normal.
Yeah.
When we see those little white dots jump around like little jumping beans or a collection of coins that you throw up in the air, those are dynamic air bronchograms. That's pneumonia.
Gotcha. So the dynamic air bronchograms are more specific for pneumonia, and the static air bronchograms are show an abnormality, but that could be just like bad atelectasis from like a mucus plug, theoretically speaking.
Absolutely.
Right? Okay.
Yeah. And the last piece that I think about is what's called the shred sign.
Okay.
So if you have a border that you can identify between the air-filled lung and then the pneumonia area lung, then the pleural line, which is normally nice and crisp and clear, will look as if someone sort of took a little rip out of a piece of paper. So the top part of a piece of paper, instead of having a straight line, the line sort of disappears. And then you see fluid, black collection of focal B lines, and then little white dots that move and bounce, dynamic air bronchograms in that space.
Okay.
So those collection of findings says to you, this person has pneumonia.
So the shred sign is just basically like the border of a consolidation, or what is? I guess like I'm wondering what is the advantage to thinking about the shred sign as a separate pathology? Is it just make it easier to be like, oh man, there's something here, kind of like with the B lines. I want to focus in that area and try and find the consolidation. Is that like maybe the advantage to the shred sign, or is there something else that's better about the shred sign compared to just looking for bronchograms?
I think it's important to remember the signs that appear. So when you see them, you don't simply say, this is weird. You say, oh, shred sign is the border between the air-filled lung and the pathologic pneumonia lung, and that's where I see it. What it also allows us to do is to ensure that we're looking at a large enough area, because you can have small areas of subpleural consolidation, less than a centimeter, and those are virus.
Subpleural consolidation being like you have the pleural line and there's like just like a little dip in the pleural line.
Yeah.
Like not like a full like lobe. It's just like a little boop, just a little triangle, a little circle, a little square, something like that. Okay.
Yeah.
Gotcha.
And then the collection of those says to me that that's pneumonia. Now, I recognize that if patients are getting admitted to hospital, that people upstairs are going to want the x-ray because that's kind of how most people think about it.
Sure.
But imagine two different scenarios. One, this is a kid who's otherwise healthy, and his sats are good. She has normal pulse ox and a relatively normal respiratory rate, and you're saying this kid's going to go home. Well, why not treat it like an ear infection and say, I see it, here are your antibiotics, go home.
Right. Yeah, that's true.
So you come in, you examine the person anyway, even though, parentheses, we know that auscultation really stinks. So we're doing that as part of the art of medicine.
Right.
So ultrasound over the lungs, and then if you see the pneumonia, you say, your child has pneumonia, here are your antibiotics.
Right.
Oh, don't we need an x-ray? Oh, no, ultrasound is actually even better.
Right.
And it's a really easy sell because how else do people know ultrasound, particularly parents of young children?
Right.
Well, they got to see their developing
Babies.
fetus with ultrasound. Yeah. And that's an incredibly powerful tool. So we don't have to say to them, ultrasound is even just as good because they still know it's great.
Right.
They saw sort of that gift of the child on ultrasound, so they think it's great.
Nice.
And what it also does is you can show them straight away. I mean, we point out sometimes what an x-ray looks like, but there's rib spaces there. It's not totally black. There's little white lines.
Yeah.
The right and left side don't look the same. So I think
it's a little
we
harder,
do that.
right?
And it's a lot harder. We think it looks crystal clear, but we'll say, see how it's a little hazy over there? And the parents nod, but in their mind, you can see that they're
actually not.
But what I do is you just go back and forth from one side to the other. You say, see this one, this is boring. You don't see anything on the screen. Boring. Next area. See all those little white lines? See those little white dots? And then you just go back from normal to abnormal.
Yeah.
And parents are like, oh, yeah, I saw the pneumonia. I see the area that's different. We now have engaged with the family.
Yeah.
They've seen we spend more time. We're looking really carefully. And you don't have to go off the x-ray and spend an hour and a half getting your image done and read.
They're on board with it, basically.
Yeah. And I think I didn't believe they would be until I've done it a bunch of times. And people are like, oh, I see it.
Great. Thanks.
So the other paradigm, in contrast to those children who are going to go home, because no one else is going to take care of them, so you can do what you would normally do with other kinds of conditions where people go home. If the patient's getting admitted, then I recognize that people upstairs are going to want an x-ray. That's kind of how they consider pneumonia and lung disease.
Yeah.
And that's okay.
Yeah.
Because what it actually has done for me is it's helped me define what their disease state is. And that's how we use ultrasound in a lot of conditions to reduce our differential diagnosis. Child with respiratory distress, they might have pneumonia, they might have a pneumothorax, they might have bad atelectasis, a pleural effusion, asthma. And what this allows me to do is once you visualize the lung and you say, oh, it's pneumonia, then we start down the road and the child gets antibiotics. You start doing your supplemental oxygen or whatever you need. And sure, we can get the x-ray so that other people can see how big it is and what it means. But I also have said, okay, stop using the albuterol. That's not the source of this kid's problem. It's pneumonia. And we can get the x-ray. That's what they're going to look at. But we already know their disease. I can put their bed in. I can start their antibiotics and do everything I would normally do. It just advances the process and makes my decision-making sort of flow so much easier.
So it helps with dispo, basically. Like you already have, I mean, it's dispo and maybe even like cognitive offloading, right? Like you don't have to think like, oh, I don't know why this kid's in respiratory distress. You're thinking about that over the course of an hour and a half or however long it takes to get your x-ray done.
Yeah.
And then you can focus on the other patient. Even if that patient's not been admitted, you're waiting for whatever labs, some antibiotics to get administered. Like you're done with that patient, right? And
Absolutely.
you can like move on mentally to another one. So, and we're all about cognitive offloading, right? Whatever can make our job a little easier, less decision making is honestly, I think, a lot better. So, Russ, I got a question for you. How, let's say you have somebody that listens to this, listens to you talk, and is like, hey, everything he's saying sounds perfectly legit. I'm on board. But how do I start doing this? Like, how do you implement this if someone doesn't have like training in lung ultrasound, right? Hasn't really like, maybe can do a pneumothorax in an adult, but like has never really done it in a kid. How do you start?
So that's a great question because I could imagine that it's hard.
Right.
Because there's not really an organ that you see. So you don't really know if you're in the right spot.
Right.
The easiest way to decide, I think, is to take something that's abnormal. Go with your standard process first.
Okay.
You're going to do your x-rays. Now, let's pick someone who is totally normal, maybe asthma. So their lungs will look boring.
Okay.
You may or may not have chosen to get an x-ray. Maybe the kid has severe distress and a fever. Not unreasonable. You go and you examine, and you could lead with this script. Hey, mom, dad, we see on the x-ray, everything looks good. Sometimes the ultrasound can give us a little bit more information. Let's just take a look. Why don't you have your child over your shoulder? And I'm just going to slide the ultrasound probe over and see if I see anything else.
Okay.
Because that's already
great.
setting you up for that. There's nothing else really to see, but we're double checking. Who doesn't like a double check?
Nope. Yeah.
Slide the
Everybody likes a
probe.
double check.
Double check. So do that lung sweep, slide down the mid-back, rib space by rib space. And of course, you know if you're going too fast, if it just goes in a blink of an eye, look at that
probe?
area. So what probe? The short answer is any probe.
Okay.
The better answer, I think that makes it so people have a thing they're going to pick. When children are young, under 5, you can just use the high-frequency linear probe because you don't need a lot of depth.
Right.
As people get older, or if the kids are bigger, curvilinear probe is my preference because I get a wider field of view.
Great.
If you use the phase array, then remember the pleural line is going to be real short because it starts out as a point of a cone.
Sure.
And you're not going to be able to get a good look. And you don't need a lot of depth because the kids are not that deep.
Right.
Give yourself at least 4 centimeters, and those linear probes only go to about 6. So that's a limit, a good thing for kids who are at school age.
Because whatever pathology you're looking at, it has to start at the pleural line for you to see it anyways, right? I mean, because if there's any air between the pathology and your probe, you can't see it, right? Because the air is blocking it.
So it's going to be either right at the pleura or somewhere pretty close to the pleura, a centimeter or 2 away.
Okay.
So slide down the mid-back. I usually do left back first because that's how the kids are facing. It makes it easier, and I'm right-handed. So I just slide down mid-back, stopping at a rib space. If I see anything that's funky, then I look around in that area. So I go a little right, a little left to look in the area where we see big nodes. Then I do right back, slide down each rib space. Now, the kids usually have their arms over their parents' shoulder, around the parents' neck.
Oh, that's what I was going to ask you. So, if you have a kid that's let's say under 4, maybe 5, so you're having the parents they're sitting on the parents' lap, legs are over their parents' hips, so their torso is laying on the parents, right?
Absolutely.
And then you have the arms of the kids underneath the parents' armpits, straight in, and then the parents are holding the head and the hips. That's exactly how I do it. Yeah, it's the easiest way to do it.
Easiest way. Yeah. And then the kids feel really comfortable. The parents can usually then see the screen.
Brilliant.
Because they're looking right at it.
Yeah, yeah.
And then after I do right back, then I just do right flank because you're right in there.
Okay. Yeah, of course. So you go posterior, then lateral.
It's the easiest to do it. The order doesn't matter. It just is practically easier to do it this way. So after we've done back and lateral sides, then honestly, because kids for the most part are not really very deep or very thick in their chest, one could argue that you've probably examined all the way through their chest.
Okay.
And their thorax. To be complete, I have the parents turn the children around, and hopefully now the kids are starting to feel a little bit more comfortable.
Sure.
So I wipe them off so that the gel doesn't get on the parents, but everyone is starting to sort of see how things go. Turn the kids around. Often what happens is in my exam rooms, the TV is over my shoulder. Brilliant. So now the children can see the TV in the position where they're least comfortable. Yeah. And we're almost done. Then I scan right chest, same sort of process, mid-clavicular line, down each rib space, pausing if I see some B-lines, because that's often the first clue. And then I sort of hone in on that particular area. Yeah. Inevitably, you go down and you think there's a consolidation, and then you look where the probe is, and it's over the kid's liver. And you go, that's liver.
Right. Because, that's a short space, especially in a little kid. It's this much is their actual front part of the chest, right?
Yeah. So I always just look down, and that's the beauty of what we do in comparison to sending somebody off to X-ray, because they can't see where other organs are. They just don't
no frame
get to
of
see
reference.
the patient. Absolutely. And then I do left chest last, just because the heart's in the way. So if I do that first, from a display perspective, it looks a little funny to parents and trainees because they're seeing something move and they think something's weird. But this is my last part because we've now said, we've looked at everything else. And I just sort of keep in my mind and say to anyone else who's watching, family or trainees, do you notice how this is boring? It looks like what people think about ultrasound who don't do ultrasound. Boring. I don't see anything.
Yeah.
So I just tell people it's supposed to be these horizontal white lines and we're not supposed to see anything. Yeah. And then on left chest, go further lateral to avoid, of course, the heart. Slide down. Yeah. And I just go boring, not boring, boring, not boring. And then if I have a question, I just go back to the rib space where there was a little something funny and look to see, do I have the findings? Focal B lines, subpleural consolidations more than 1 centimeter. Those little dancing, what did you call them? Pneumonia worms?
Pneumonia worms, yeah.
Pneumonia worms.
Shout out to Rosanna Couture. That's my resident who like coined the term pneumonia worms.
We'll put it in there. Thanks, Rosanna. I think about them as like little white jumping beans.
Yeah.
And that shred sign, which is the border between the air-filled lung and then an infected pneumonia area lung.
Okay. Yeah, brilliant. So, question: Do you warm the gel?
Oh,
because like sometimes it's a little bit cold, and even like adults are like, oh, like when you put the ultrasound gel on their on their sides or whatever. Like, do you warm it for kids?
Yeah, so I think that the funny part in adults is we usually say, oh, the gel's cold, and then we put cold gel on anyway. So it's like, the gel's cold. Sorry, I can't help you. I know this is going to stink. And so I have a gel warmer. They're about $100.
Yeah.
And I
really?
keep that. Yeah.
Okay.
I just keep it in our workroom, and I change out a bottle of gel that remains on the ultrasound machine with the warm gel, and then just flip them back and forth. You can use that for single-use packets also. Yeah. Don't put it in the microwave, though.
What happens if you put it in the microwave?
Well, it heats unequally. And,
nice. I've actually noticed that. Like, first off, it absorbs heat so fast. Yeah. Like, so I've done this before. Like, I'll heat it up and put it in there for like 10 seconds, and it's too hot. It's like too hot after like 10 seconds. And then, so what I'll do is I'll stir it a bunch to make sure it's even, and then I'll stick my like clean finger like in it to make sure it's like evenly distributed. As somebody who sometimes does not have the ability to have a gel warmer, like that's what I've done in the past. But gel warmer would be amazing though if I had that.
Yeah. I mean, they're cheap, $100, and you can even use them for single-use packets. So if you're using lubricant jelly or something like that, then that'll work out really well.
Yeah.
And then theoretically, if you're not using your ultrasound too long and you're heating it up, then that could make it more likely that some germs would grow. So. Take out the grain of salt.
That's like the one downside. So like if it's like been hanging out in there for like, a week, might not be the safest thing to do is what you're saying.
Yeah. I mean, we're going to clean our probe before and after. Yeah. We're minimizing our contact and our time, but just to minimize any infectious risk, that's the easiest way to do it is use single-use packets or go through your gel fast. Yeah. Scan a lot.
So one thing that I just want to like just mention briefly in passing is the whole, like auscultation thing. We kind of like touched on it. And I think that from like you and my perspective on it, like it's very obvious that auscultation doesn't work very well. Now, I know that there's actually really good literature in the adult literature that shows that auscultation basically can't really be used at all for its sensitivity, and the specificity really isn't that great. Is there literature that exists for this? Like, apart from you and all the other people that do this anecdotal, like what we see, is there any like literature that backs up what we see clinically?
I can include for you some really good stuff that talks about auscultation and what specific findings are when they did sort of multi-center studies about what auscultation was, and then compare those to findings for pneumonia. And they just stink. It's so disheartening. Yeah. Because we want focal breath sounds to be an indication that sound waves are traveling better or worse through different areas that are normal or infected. Yeah. And they just don't help. Right. One of the features which helps and is the best is wheezing.
For pneumonia?
Which is just demoralizing, but it's a focal area of wheeze.
Yeah. Because I mean, I guess the airways are narrowed because of like pus or whatever that's in the airways, right? Yeah, I guess that makes sense. Wow, that stinks. So I mean, it's weird because that would be like specific for pneumonia, but also it's specific for asthma. It's specific for obstructive airways disease. Yeah. All right, sweet. So we'll include that in the show notes. And also with this auscultation, like it's very subjective. Like what sounds like something to me might not sound like it to you. Versus ultrasound, that it's pretty objective. I think like you see pneumonia worms or you don't. I remember when I was in medical school learning about like percussion, like one of the instructors, you're percussing, you're doing your whole thing. And I'm a classically trained musician. Like I started playing the violin when I was 4. I switched over to the viola when I was older. That was my major in undergrad was music. And I knew that I forgot what rib space it was, but like, this is where the timbre changed. Like, I'm like, I know it's this rib space. And my instructor was like, no, it's up here. And I was like,
I got to tell you, dude,
okay.
no way.
Okay. No, I was like done with it. Like, I'm like, whatever you want. But like, I know that like where she thought the diaphragm was incorrect, and where I thought the diaphragm was correct, because I could hear the difference. And like, let's just say for like a pleural effusion, this whole percussion business for like, differentiating between like fluid or lung, like, can you imagine like if we didn't have ultrasound, and we were basing it off of this completely subjective test? And it's the same thing, I think, with pneumonia. I mean, it's just it's so subjective. And if you have something easy at the bedside, non-radiant, that you can include the family in, because that's another big thing, is that if the family feels like they can hear, they can see it, I guess, see the sound waves. It's almost like they have some aspect of control in the situation, which when your kids are sick, you feel like out of control, you know what I mean? So, there's so many good things with using this lung ultrasound in general, and then specifically in kids. I think probably the most helpful application of lung ultrasound is specifically peds.
Yeah. The idea of sort of involving the family is just an incredible tool. Because you lead with, okay, this is what we're going to see. It's boring. And I use that word, boring, because it doesn't look like anything.
Right.
And then I say, if there's pneumonia, we're going to see these white lines, parentheses, that means B lines. Yeah. So as you go down, inevitably, if it's on the left side, that just happens to be where I start.
Okay.
But you can start anywhere. Yeah. It's just by habit. That's what I've done. So inevitably, if it's right there, once I say the words, you see these white lines, parents go, oh, like that? And they point to the screen. And I was like, yeah. And then I say, well, we're going to look a little closer to make sure that it's not just a little bit of mucus.
And by you see these white lines, you mean B lines, right?
B lines. Yeah. So the parents are like, oh, B lines, because they shine from the pleural line. They go all the way down. And then we move our way down. And then you're just talking to them, just like you would talk to another physician. Oh, we see that? Yeah, the little collection. Oh, it's just that little collection of white lines, but we don't see the pneumonia. That means it's just a little bit of mucus. And they're like, okay, keep going down. And they said, what do I see here? I was like, it looks boring. That means it's normal lung. That's what we're hoping for.
Right.
Down, 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 down. The whole study takes like a minute.
Yeah.
And then you're finished.
You're done.
And you go, nope. Yeah. And then we've all been in the circumstance where either if you have kids and you have another person who's helping you take care of them, and you're at home and the other person goes to the doctor, or you're taking care and there's another parent at home, it's usually one will call the other one and say, oh, I'm here with the doc and this is what they're doing. They say stuff like, oh, yeah, we didn't do the x-ray because we use this ultrasound. It's this cool new thing.
Right. Yeah.
And I was able to see the lung and I saw that it looked boring. And they just quote your words. Yeah. No pneumonia? No pneumonia. They looked at every space. They did his back. They did his sides. They did his chest. And it's all good.
Yeah.
We're great. We don't have to worry about it.
Yeah.
And you go, okay. Yeah. And that's, of course, if the kid's going home.
Yeah.
But if they're not, then it just helps you figure out what it is that you're going to do and how you're going to approach this kid. Continue with the nebs or stop the nebs. And you're like, oh, the kid's got pneumonia. Right. And then the x-ray comes back and you go, oh, someone goes, oh, look, he has pneumonia. And I always think like, of course he has pneumonia. We saw it.
Right. We knew this. This is old news.
We knew it. Yeah. And then to be able to distinguish between atelectasis versus infiltrate is just awesome, because it gets treated as, oh, there's a little hazy thing right there. Let's give them antibiotics just in case.
Yeah.
But we know that just in case is just like a waste.
Right. Yeah.
So instead of just in case, let's just
diarrhea.
Let's just
give them diarrhea
do
and
it.
a rash.
Yeah. Let's just do it. Let's just know.
Yeah.
Otherwise, it's like, well, it kind of could be. Because x-ray misses and confuses atelectasis and infiltrate about 25% of the time.
That's intense. Yeah. 25% of the time, huh?
Yeah, so its sensitivity to rule out disease is about 75%. But it goes back to the idea of they being the radiologist or anyone who looks at the x-ray, they can't see whether these air bronchograms move or not.
Right.
So they just say, well, hey, atelectasis first infiltrate. And it gets us upset, but it's not their fault.
Right. Yeah.
They can't see the air move.
Right. They're doing the best they can with the information they have.